AETCM welcomes everyone for today's clinical case presentation to be done by Dr. Manna.
Thank you, sir. A 63-year-old female was brought to her ER with a history of altered sensorium since one day. Initial 10-second assessment, patient was drowsy but arousable, but patient was not able to obey my commands. Primary survey, airway was patent, there was no pooling or gurgling secretions. Breathing, her respiratory rate was 21 per minute with a saturation of 89% in room air. And she was not tachypnic, there was no use of axillary muscles of respiration. Auscultation wise, there was scattered crepitations bilaterally. Circulation, her heart rate was 108 per minute with a blood pressure of 114 by 54 with a map of 74.
1 minute. See, at this stage, SpO2 is 89 on room air. What do you suspect?
She came with an altered sensorium, sir. Maybe she might be aspirating because
but airway
of the
is
patent. There can be a tongue fall also.
So what about breathing? What are the parameters you assess in breathing?
Use of accessory muscles of respiration, rate of respiration.
What?
Rate of respiration.
Chest
Here
raise.
what she is telling is respiratory rate is normal. Correct, no?
Yes, sir.
Rate is normal, but the most important thing is ventilatory excursions. So that always counts. So the rate may be okay, but the tidal volume of 500 ml for a normal adult should reach the lungs. That will be gauged only by the ventilatory excursions. Adequate chest raise should always be there. And then anything else? Regular breathing. Okay. These are all
What is the
important.
age of the patient?
63 year.
What is the weight of the patient?
Weight around 65 kg, sir.
Obese?
Yes.
Obese means for the height she is obese or not.
Yes, sir.
Right,
Yes, sir.
What is the size of the neck? Height of the neck?
Short neck, sir.
Short neck.
Short
What
neck.
else you see? When we discuss, there is a chance of aspiration like you told. But as a postgraduate, you should think something else.
One thing is mainly the patients with the normal, we are expecting a tachypnea in this patient in view of this desaturation.
But tachypnea is
It's
not
not
there.
there. So we should cause any brainstem any issues there causing a
Stroke.
bradypnea or an opioid or any drug overdose is a possibility,
Okay.
sir, another thing. Or else we have to suspect that patient may be a chronic COPD or any chronic lung issue.
She's a female.
Female.
Central sleep apnea syndrome.
Central
You have
sleep
to always
apnea.
think about sleep apnea syndromes. Their patient will have hypopnea, like this patient will have lower breathing rate, desaturation, loss of consciousness. Everything is explained, but it is for a short time.
Yes.
That apnea period is short time. Even then, some patients, when they have some problem, like sleep apnea patient is having some altered behavior, they directly go to the apneic state or hypopneic state. That also you should keep in mind. Many female patients, obese patients come with sleep apnea syndromes.
Disability, her Glasgow Coma scale was E3, V3, M5. Bilateral pupils were 2.5 millimeter reactive, sir. At this point of time, GRBS was checked, that was 135. Exposure, her temperature was 100 degree Fahrenheit.
No, that's okay. What is the immediate step you will do in this patient? Immediate step. Desaturation is there.
We'll keep the patient in a proper position and first we need to look for any upper airway obstruction like tongue fall or something. If there is any features of tongue fall or something, we should give a jaw thrust or we should put a nasal airway.
That is very important. Immediately you have to put a nasal airway if possible in this case. Okay.
So this patient, there was no added sounds or features of tongue fall.
As your guidelines, this patient has to be intubated.
Yes,
But
sir.
if you go for a nasal airway in this patient, sometimes you can avoid intubation. That's the only thing.
Everything should go from the basic steps.
Yes, sir.
Directly we need intubation only in patients who are about to crash. Otherwise you can try for the basic man. So you can start with the airway manual, jaw thrust or head tilt, chin lift, and then nasopharyngeal airway. Adjuncts. These two things in many patients will get. Good.
So this patient was kept in a proper position. There was no added sounds. So she was started on nasal prongs, sir. 1 liter oxygen was started and set.
I don't know 1 liter oxygen whether it is useful or not. What is one? What is a room air? Normal room air.
21%.
So how many liters if you calculate? It is nearly 2
24.
liters.
24.
2 liters. 1 liter oxygen, it is not going to do anything. Just for patient satisfaction, sometimes we keep. Otherwise, 1 liter oxygen is not going to help this patient at all. If you want to start oxygen with nasal prongs, at least 4 liters you have to keep. Mask more than 4 liters, 5 liters you have to keep. That is the ideal thing. Don't never start 1 liter. Correct, no, sir?
Only you go for 1 liter oxygen with nasal prongs.
Sir,
How much you can maximum administer with the nasal
nasal
prongs? How
prongs
much
maximum 4
percentage of oxygen?
4 liters, sir.
4 liters. How much percentage you will get from the nasal prongs?
30 to 40.
Around 30. Okay, you told the oxygen saturation is 89. Will it be okay? You are using a nasal prong with 1 liter of oxygen, or you will consider for any other option?
Ideally, we need to increase the oxygen, and depending on the patient requirement, we need to reduce.
Reduce, okay. So what could have been done instead of the nasal prong?
NRBM can be started.
NRBM. So how much percentage you can get oxygen in?
NRBM about 15.
More than 95%.
More than 95%.
Around
Favority.
90%. Okay. How much the per minute ventilatory flow liter per oxygen?
More than 10 liters, sir. 15 liters
were
can be
about
given.
10 liters. Where will you get the 100% oxygen?
By a gun mask.
Bag mask ventilation with 15 liters or more oxygen. Okay. So whenever saturation is low, immediately you can go for an appropriate way of oxygen administration. Good.
Then an arterial blood gas was taken, sir. It was showing a pH of 7.47, PCO2 of 32, and bicarbonate of 21.9. The PO2 of 66%.
66, what does it mean? Arterial sample.
Oh.
So is it normal? What is the normal range of pH?
Between 85 to 95, sir.
So that also shows hypoxia.
Hypoxia, sir.
Okay.
So it's a respiratory alkalosis, sir, in this patient. Then she was having fever, so 2 large bore IV
Now, after seeing the pulse oximeter, the ABG value, what method did you take for correcting the hypoxemia?
Respiratory alkalosis is there, associated with hypoxia is there.
Okay.
So we started her on oxygen, sir.
Oxygen, how?
Oxygen.
But when you have hypoxia and desaturation is there, how do you expect respiratory alkalosis in this patient?
Rate is
Sir,
also
probably the initial respiratory rate may be wrong, sir.
Something
Maybe
is
it
wrong in this whole presentation. Something is wrong. You are telling there is a desaturation of 89. Now you are telling respiratory alkalosis. To have respiratory alkalosis, patient should have tachypnea, carbon dioxide washout, and oxygen levels may be increased. Something is wrong. Somewhere something is wrong. That's why you are getting a false report either, or your ABG value may be wrong. That is also possible. They are doing it in a machine. So somewhere something is wrong.
What is PaCO2 value you told?
PSA 32.
32.
Then she was having fever, sir. So we have given her 1 gram paracetamol IV dose.
No, I am not getting your oxygenation status still.
That is the problem. You have to correct it.
So you have to go by A, B, and then C. First you have to correct the oxygenation part. See, in addition, patient is having fever, so O2 demand will be more. Okay. So one measure, only nasal prong is going on.
Oxygen via mask is required, sir.
Or ordinary mask.
NRBM.
NRBM, good. Any improvement in the saturation did you notice after this pulse oximeter value?
Yes, sir. Actually, after starting with mask, her saturation improved to 100%.
100%.
It is taken after this improvement?
No, sir. Immediately.
Okay, this will be told step by step. So what is the problem? How did you correct? Whether the reassessment on the spot, whether there is any improvement, status quo, or deterioration further, what is the other alternative method you changed over to, how the response. Then you go for the breathing, then go for the circulation. Okay, carry on.
Ample history, there was no allergies. Patient is a known case of diabetic. She is on human atrapid for that. And she is having diabetic neuropathy on pregabalin. She is hypertensive. She is not taking any medicine for that. She is having dyslipidemia.
Pregabalin, what type of drug it is? So basically a sedative. It has got a lot of other actions, but it's basically a sedative. So some patients like this, there is a chance of overdose of pregabalin. You have to keep it.
Then she is having a past history of CVA with a coronary artery disease. She is taking sorbitrate, ticagrelol and Lasix for that, and she was diagnosed to have organic psychosis that same year, and she was on risperidone for 1 month. And one document is telling that she is having a history of COPD also. So maybe the desaturation may be because of the COPD.
So what do you suspect in COPD? Desaturation alone or anything else?
COPD cannot
type
make
2 respiratory failure.
Type 2
I will get
Type two
carbon dioxide
Carbon dioxide
excess
retention.
also, but you are
This patient, it is
ABG
respiratory
also
alkalosis.
normal, 32. Okay.
Her last meal was 1 day back,
It's a
sir.
type 1 respiratory failure.
Yeah, this patient type 1 respiratory.
What are the reasons for type 1 respiratory failure?
It can be seen in pneumonia, pulmonary edema.
Pulmonary embolism. This patient, any patient who is having type 1 respiratory failure, if you are not getting any lung findings, you have to keep in mind that there is a chance of pulmonary embolism. I am not telling all these cases are pulmonary embolism, but you have to always keep. So that is the most dangerous diagnosis. If you miss that, patient may die. Okay.
Events. Patient was asymptomatic the day back. On the day of presentation, since morning, patient was having altered sensorium and patient was speaking irrelevant things, and she had a history of involuntary micturition, involuntary passage of stool. There was no history of any seizures, no history of vomiting, no history of any drug overdose, no history of any weakness or any alcohol intakes or any toxin intakes. That was the only history which was available. On examination wise, patient central nervous system, her GCS was E3, V3, M5. She was disoriented, drowsy but arousable. She was moving all 4 limbs, but she was having rigidity, maybe because of age-induced Parkinsonism or something.
You just want to keep rigidity for only for Parkinsonism or something, some differential diagnosis you think?
Seizures.
Seizure, you don't get rigidity. It is flaccidity actually after seizure.
Ongoing.
Don't think anything else. NMS. You have to keep in mind that NMS is a possibility. This patient is taking antipsychotic drugs. NMS is definitely a possibility. Patient is having fever, rigidity is there. So you have to keep it in mind. Whether it is due to Parkinsonism or that is secondary. What type of rigidity you will get in Parkinsonism?
Cogwheel rigidity.
Cogwheel. What is cogwheel?
Rigidity will be like wheel. That means
It will be
broken.
It will be broken. Here, what is the type of rigidity?
It was almost like that.
Cogwheel.
Cogwheel.
Okay. Bilateral or unilateral?
Bilaterally.
Okay.
In NMS, it will be uniform rigidity.
In NMS, it is lead pipe type of rigidity. Okay.
Sensation and power could not be examined, sir. There was no neck stiffness. Plantas were bilaterally withdrawal responses, sir. Respiratory system examination, trachea ascended, chest movements were bilaterally normal. There was no use of accessory muscles of respiration, and there was bilateral scattered crepitations, no wheezes. Other system, cardiovascular system and per-abdominal examination was normal, sir. It was a case of an altered sensorium under evaluation with the hypoxia, sir, maybe secondary to COPD or aspiration.
What is the glucose level?
135.
135.
We went into investigations, sir. Investigations, our total count was 17,000 with a neutrophilic predominant, neutrophils of 84%, platelet of 2 lakhs and hemoglobin of 12.6. Her thyroid function and LFT were normal. Her urea was 187 and creat of 4.31 with and ammonia of 29.9. Electrolyte.
What do you think that urea creatinine ratio?
Urea was high, sir.
Disproportionately high.
High.
That goes in favor of a
Pre-renal failure. Then electrolytes, her sodium was 135, potassium was 5.2 and calcium was 11.15 with the albumin of 4.2. Corrected calcium was coming around 11.15.
The albumin is?
4.2.
Okay. Albumin is slightly high.
Yes, sir.
Or normal?
Albumin 4.4.
3.5 to 4. Normal.
And globulin was 6.07.
Globalin is
6.0, sir.
Globalin is high.
Globalin is high, albumin is 4. So age reversal, sir.
Okay.
And hypercalcemia potassium was 5.2.
When the globulin is high, what will happen to the like calcium? Any type of protein, when it is elevated, there will be a pseudo elevation of the calcium, that you should understand. This is called a pseudo hypercalcemia. So sometimes in multiple myeloma also you can get it like that. Calcium will be elevated. Some types of protein will be elevated. Here paraproteins like globulin may be elevated. So sometimes this may be falsely elevated. We don't know. Sometimes we have to keep it in mind when the globulin is disproportionately high, like in multiple myeloma and all. The calcium elevation can be due to bone destruction, but there is a chance of pseudo hypercalcemia in this patient. Okay. Like when you have low calcium, you correct it, no? Like this also possible.
So this patient, since there was a hypercalcemia and hyperkalemia, we asked for an ECG. ECG was showing a rate of 105, rhythm was normal, a normal axis, PY was normal, QRS complex was white QRS complex with the RBBB pattern. Patient was already having this right bundle branch blocks with the QTC of 436.
Nearly normal.
Normal QTC.
What do you think about RBB in a female patient? Is it commonly seen, RBBB in a female patient?
No, some patient having ASD.
Okay. In male patient, RBB is well known. It's a normal phenomenon. But when you are seeing in a female patient RBB, there may be some underlying disease. We don't know whether, but it will be there definitely. Whether it is a lung disease, whether it's a heart disease like ASD, whatever it is. You have to keep in mind.
Then a chest X-ray was asked, sir. Chest X-ray was showing, actually there was no opacity as a chest X-ray grossly appeared normal, sir. So in this patient there was a infection, total count was raised, neutrophilic predominant, and CRP was elevated with electrolyte abnormality and renal failure. So we did an ultrasound abdomen. Ultrasound abdomen was showing features of raised renal echo texture with maintained CMD. So favoring to be an acute kidney injury. And bedside IVC was also assessed. IVC was 1.5 centimeter dilated, sir.
Okay.
So we went ahead with the management part, sir.
You have some 3 problems here. One, the patient is having altered behavior. Another one is hypercalcemia, sir. We definitely don't know whether it is a real hyponatremia or something, hypercalcemia or pseudo hypercalcemia. But this patient is having renal failure. Okay. So all these things you have to treat now.
So in this patient, renal failure, hypercalcemia, hypernatremia and infection is there. So since
take care is the unconsciousness part, airway breathing, that you have taken care.
Airway at present she is maintaining her airway. Breathing wise also she was maintaining saturation. Actually she was maintaining with 1 liter. She is a COPD patient, so we have given only minimum oxygen just to prevent tachypnea. Then circulation wise tachycardia was there, otherwise
there is fluid overloaded. According to you, there is renal failure, the IVC is full, so you and calcium is high. So you want to avoid calcium, avoid fluid from the body, remove. What you do?
Usually in hypercalcemia we manage it as give fluids along with Lasix, but in this patient already patient is in a fluid overload state, so we will be preferring to give furosemide. According to the response and urine output, we will be planning on giving fluids according to the response to the Lasix.
So have you given Lasix?
Yes, sir. So
Lasix, was the response?
Patient was responding to Lasix. We catheterized the patient. We started her on Lasix. Initial 40 mg bolus dose was given. Then she was responding to that. So we have given Lasix as an infusion, sir.
Then we have to check what happened to the calcium. What happened to the calcium?
Calcium was improved. First calcium was 11.2. Then calcium became 10.8. Like the calcium was improving, sir.
Okay. If suppose calcium is not here, there are multiple possibilities. Hypercalcemia is there. One is pseudo hypercalcemia because of hyperglobulinemia. that will keep it in one side. Other one is it can be due to multiple myeloma as such, hypercalcemia, renal failure, all this. Other possibilities are there, like hyperparathyroidism, then sarcoidosis. How do you treat all these things? If the hypercalcemia is due to real hypercalcemia, how do you treat it?
Actually, first we need to evaluate for the causes.
The reason. What investigation you do?
First we should send for the parathyroid levels.
First we should send the phosphorus level. Okay.
Mm.
Depends on the phosphorus level, you have differential diagnosis. Then parathyroid hormone level.
So depending on the phosphorus level, there can phosphorus level. It can usually in hypercalcemia phosphorus will be low, but in this patient it was high. So
that may be due to renal
failure. Then parathyroid levels should be sent. Parathyroid level can be low, normal, or it can be high, sir. If the parathyroid level is high, then that can be because of hyperparathyroidism or most commonly parathyroid adenoma or something. Or if the parathyroid level is normal or low, then that can be related to some malignancy. It can be malignancy and metastasis in causing parathyroid related peptide elevation will be there, which can cause a hypercalcemia.
Okay.
So we should evaluate for that. So in this patient, parathyroid level was sent, still awaited, sir.
Okay. Any
So,
other investigation you want to do? Any other history you want to take from the patient bystander?
Drug.
Which drug?
This patient is having a psychosis, so lithium intake can
Lithium
cause
intake should be ruled out. Whether a patient is on lithium, it's one of the common cause for hypercalcemia.
Then other drugs like vitamin A, vitamin D, or
vitamin D is very important because many patients are now taking vitamin D. Vitamin A is unlikely because nobody takes vitamin A without any clinical prescription. Vitamin D is an over-the-counter drug. Many are taking it continuously, so that should be ruled out.
Then ACE levels, in case of sarcoidosis, ACE levels will be elevated.
Okay.
Like that we have to evaluate for hypercalcemia. In this patient there is a hypercalcemia with hyperphosphatemia and parathyroid levels are still awaited.
So you have to treat hypercalcemia and
hyperphosphatemia.
How do you treat it? What will be the best option if you are given an option? What is the best option for this patient? Dialysis. Dialysis is the best option. Whatever it is, dialysis will correct all problems in this patient. As an emergency physician, you have to treat hypercalcemia, hyperphosphatemia separately. How do you treat both?
In this patient, we have started on Lasix. So patient is responding to the Lasix, urine output is there, and that can be done.
Once the urine output improves, then you have to add fluid also. Initially we are not giving fluid, but ultimately this patient will be fluid depleted if you start Lasix. Then you have to give fluid and forcefully you have to diurese the patient.
Then we should depending on the IVC we'll start on fluids also. Dialysis is usually indicated if
we'll finish this. One is fluid with Lasix. Then
hypercalcemia, zoledronic acid is.
Zoledronic acid here we cannot give because
renal failure is
we don't give.
Steroids are advised in case of hypercalcemia.
Especially due to
malignancy.
Malignancy and sarcoidosis. Both you can give. Okay.
It will reduce the absorption of calcium and from the bones and the intestine and will increase excretion.
Okay.
Then calcitonin.
How do you give calcitonin?
Calcitonin can be given either IM or subcutaneous calcitonin 4 to 8. Not nasal. 4 to 8 international units per kg can be given every 6 hours.
Or you go for dialysis. Hyperphosphatemia?
Hyperphosphatemia, similar furosemide can be given. Then calcium binders, phosphate binders.
Okay.
Phosphate binders. And ultimate step dialysis if at all required. Then this patient is having hyperkalemia also. So hyperkalemia can be managed either by shifting the potassium or by excreting the potassium.
Yeah,
so
already
Lasix is given.
Lasix can remove everything. Okay.
Then infection is there for this patient.
What is the evidence of infection?
This patient is having maybe an aspiration.
No, that is not correct. You have to tell specifically what is the evidence of infection. Scattered crepitation at this age is not a finding of infection. It can be seen in many normal patients also. You get crepitation. Elderly individuals, because of minimal fibrosis, they can have crepitation. Don't take it as an infection. Counts are high. That can be even in malignancy also. So what is the evidence of infection in this patient?
Fever, altered sensorium, and acute kidney injury.
So what infection you suspect? You suspect any urinary tract infection?
Female.
Urinary tract, is there any pus cells in
Yes,
the...
sir. Yes, sir.
Okay, so treat the urinary tract infection. In that direction you should go. Okay. So what antibiotic you want to start?
We'll start on third generation cephalosporin or a Penicillin tazobactam.
Okay, whatever it is. Suppose you want to intubate this patient in emergency room. This patient requires your intubation mechanical ventilation. How do you manage?
Do you plan for an intubation for this patient? Airway is normal, and breathing is normal.
This patient we are not planning, sir, but if at all the patient's sensorium is worsening, patient is not able to maintain her airway or...
you told altered sensorium, the patient. See, with this treatment, whether the patient was improving, the mental status was improving, or status quo, or...
Status quo, sir.
Status quo. Then airway is normal. Airway protection, there is no 100% assurance. So we can think about going for an airway protection by way of a definitive airway. Okay. Then how will you proceed with?
For preparation, sir, in this patient already this patient is having multiple issues. Hypercalcemia with the hyperkalemia is there, so we should anticipate a risk for arrhythmias and all. So drug selection should be depending on that, sir. Okay. So in case of hyperkalemia, hypercalcemia and all, the non-depolarizing muscle relaxant can act for a longer period of time. So as a result, low doses are usually preferred, sir.
Both will act. Non-depolarizing muscle relax also in hypocalcemia will be acting longer time. In hypercalcemia also, unprecedentedly prolonged action may be there. Okay.
Then there is a risk of aspiration for this patient already is having altered sensorium.
Yeah. See, what is the last meal?
Last meal was
we asked for this patient.
1 day back.
Is there any importance?
Yes, sir.
Right.
Because if the patient has just come out, came after taking the meal and all, there is a higher risk.
For all practical purpose, the patient is in emergency is considered as a full stomach patient. So airway protection is also mandatory. Okay, good.
Then usually in hypocalcemia, we will be anticipating features of tetany, muscle rigidity and all. Hypercalcemia.
So what way it will be?
Mouth opening will be difficult.
Trismus. Okay, good.
And muscle rigidity will be there, so we will not be able to paralyze the patient. And mouth opening and introducing the tube will be difficult, sir. There can be a vocal cord, maybe vocal cord opening will not be there, adduction will be there. Then
how will you proceed with? First and foremost,
prepare the patient.
Okay, prepare.
So first we should look at the airway.
Airway assessment. Okay, mandatory for every patient. You have to go for the proper airway assessment. Why? You plan for rapid sequence intubation or planned intubation?
Depending in this patient, planned intubation only.
Okay.
So we should look for the neck mobility. We should look for the mouth opening. We should look whether the
all the essential things for the airway, for the one for ventilation and another for the laryngoscopy and the intubation. This should be done. Next.
Pre-oxygenation should be done.
So why do you want to do it? Only if you are making sure that we can able to pass a tube, or we can able to properly ventilate with bag mask device even without the tube. You can give muscle relaxant. See, if there is no surety of either bag mask ventilation or intubation, do not give any muscle relaxant, because the patient is spontaneously breathing, saturation is now maintained, airway is presently okay and breathing is okay. You are going to paralyze the patient and you are landing in shock, then will be a problem. Okay, this is the most important thing you have to assess before administration of the muscle relaxant. Okay, induction okay, still the spontaneous respiration may be maintained unless otherwise you are giving the overdosage of induction drugs. But muscle paralysis should not be done unless otherwise you are very confident about Either you can ventilate without endotracheal tube with bag mask ventilation, or you can able to pause it. Okay.
What happened to this patient after your initial treatment?
This patient actually calcium level was improved, calcium and potassium level was improving, sir. So and meanwhile we have sent for the hyperparathyroidism evaluation. The evaluation
Parathyroid
of
hormone,
parathyroid
ACE levels, phosphate anyway you got that.
And blood cultures, urine, we sent for the
Chest
urine.
X-ray is normal.
Chest X-ray is normal. Urine was showing numerous pus cells, so urine cultures were sent.
Culture anything positive?
No, sir, results are still awaited.
Okay.
Then because since there is an altered sensorium, we should evaluate for that also, sir.
When will you evaluate for altered sensorium in this patient?
When all the correctable causes are...
All the correctable causes like uremia should be corrected, hypercalcemia should be corrected, hyperphosphatemia should be corrected. Even then if the patient is having altered behavior, then you have to investigate. Okay. You can take a baseline CT and rule out subdural hematoma, all these things, elderly individual, bleeding and all, you can rule out. Okay. But after that, if you want a detailed investigation like MRI or LP study, then you have to correct all these correctable causes. Then only you should go for it. Okay. Any CT, anything was done for this?
This patient CT brain was done, sir, which came as normal, sir.
Normal. Okay. What is the ventricle size in this patient? Ventricle
it was normal only. She was having past history of posterior circulation stroke, so all gliotic changes because of that was there.
Okay.
And nothing else, sir.
Because normal pressure hydrocephalus is one condition in elderly individual can have all these features except that urinary infection. Okay. NMS is ruled out. Muscle enzymes?
Creatine kinase came as 859. Sir.
Slightly elevated, but not in favor
More
of the
than
NMS.
1000.
It may be due to small rigidity or injections, whatever you have. Okay. Suppose the muscle enzymes are elevated. Will this patient fit for NMS?
There is fever, muscle rigidity, and altered sensorium.
Drug intake is there. Renal failure is there. How do the patient develops renal failure in rhabdomyolysis? It is due to rhabdomyolysis. Somebody is having NMS, they develop rhabdomyolysis, and that produces your elevated CK. That produces renal failure. So if the patient is having elevated CK, then all fits into a different diagnosis, that is NMS. Since that is not elevated, it is something else. The treatment is almost same. You correct all these things, fluids or dialysis, everything is same. Anything else?
So in this patient, for the intubation purpose, you can reduce the dosages of analgesics, induction agents, sedatives, and muscle relaxant of choice. So you are going to for a planned intubation, not rapid sequence.
Rocuronium.
What you should avoid, that is the thing.
Hypercalcemia is there, sir. So better to avoid hypercalcemia, better to avoid succinylcholines.
Okay. So renal failure is that?
Renal failure is.
Which is the ideal method? Tracherium. If tracherium is available, still better. Okay, good. So it is an auto metabolism. Okay. Neither by renal or liver, it depends upon its metabolism. Okay, good. Hoffman's degradation.
Hoffman's degradation.
Okay,
Good
Thank
question.